Welcome to GN in 10, a bite-sized podcast brought to you by the International Society of Glomerular Disease. Our hosts are nephrologists and glomerular disease experts, Dr. Kenar Jhaveri of Northwell Health and Hofstra University on Long Island, New York, and Dr. Koyal Jain from the University of North Carolina, Chapel Hill.
This is Kenar Jhaveri and Koyal Jain. And it's usually Koyal introduces what she wanted me to introduce today because it's a NephMadness episode, and we have a special today on C3G. So we welcome our two guests.
We have Dr. Matt Sparks and Dr. Aarushi Varshney who've joined us, and so really excited to have you here. Go ahead and tell us a little bit about yourself.
I'm Aarushi Varshney. I'm one of the Duke Nephrology Fellows, second year, and my interests are glomerular diseases, so I'm very excited about this podcast and this NephMadness topic.
Yeah, hi everyone. This is Matt Sparks. I'm a nephrologist at Duke, and I'm also the co-creator of NephMadness, and I'm very excited about a topic that really has seen just such a groundbreaking changes over the last year. So this is going to be a lot of fun.
Thanks, Matt. Thanks, Aarushi. And people who don't know what NephMadness is, too bad, because by this time you should know what that is. And there are a lot of videos about it. It's basically a fun game that you have topics that compete against each other. The two topics we have today for C3G is the diagnosis of C3G versus the treatment of C3G.
I wanted to tell the group, why did we choose these two topics? And the reason why is the executive committee for NephMadness. We wanted to highlight that the diagnosis is pretty challenging, and we don't really have good specific tools to do that. And the implementation of drugs really depends on a good diagnosis. And we felt that it was really important for us to do a great job educating the community about the pitfalls and the challenges of diagnosing this disease. So with that, I'll hand it over to Dr. Varshney, who really did a great job on doing the write-up for this region.
Thank you, Dr. Sparks. This is an ultra-rare disease, and it's an entity that we're still learning to this date. And we have definitely learned a good amount compared to last couple of years. In regards to child diagnosis, I would say this is a diagnostic disease that needs to be diagnosed through a tissue biopsy, and it comes down to immunofluorescence staining dominance. Previously, the nomenclature was MPGN and their subtypes, type 1, type 2, type 3. And now when we are learning a little bit more about immunofluorescent, the way we diagnose this C3G itself is by looking at the order of magnitude of C3 depositions on immunofluorescent. So if it's more than 2 order of magnitude compared to other immunoglobulins, then we could say this is definitely a C3 dominant disorder compared to immune complex MPGN. However, this is a subjective test. We don't have lab findings that are more specific or sensitive to this date. So I'm hopeful in the next couple of years we will learn a bit more about, and hopefully we will have more specific assays. But right now, this is what we have, and we're trying our best to make most out of it.
But I think for our listeners, if you had read one of the old textbooks of Robbins or any nephrology textbook, the old classification was EM-based. And
Right.
what Aarushi is proposing is a new classification that has been around for 10 years. It's immunofluorescence-based for MPGN. And that led to kind of birth of a disease entity of C3G because there were diseases that were popping up that were mostly C3 dominant and immunoglobulin negative. And that's where what you were talking about. But what about dense deposit disease? Koyal, where do you put that one?
So I will say that dense deposit disease, which was traditionally MPGN type 2, is also part of C3G. I think people think of C3G as C3GN only, but in reality, when you have 2 or more magnitude higher staining with C3, with or without immunoglobulins, then you can put them in this category of C3G. And if you have, sort of more like an MPGN glomerulonephric pattern, you call it C3GN. But if you have those ribbon-like deposits within the basement membranes, then you can call this the dense deposit disease. And both of these together come within the category of C3G. I will also say that this nomenclature had been proposed close to a decade ago, because I'm pretty sure when I was a fellow, it had just come out. But I will say that even then, I would see some path reports coming from other institutions, other places, which would mention MPGN as opposed to immune complex versus C3G. And I will say personally, I found this new immunofluorescence classification a lot more helpful in diagnosing and also treating, figuring out the right treatment for my patients. And so I'm really glad that we're talking about this today.
So if it's this easy, right, Matt, like it's C3 dominant, doesn't matter dense deposit disease or C3G, why is diagnosis such a big issue? I mean, it sounds like a slam dunk to me.
The problem is the complement cascade is very important in many diseases. In this entity, which we're describing here, it's autonomous sort of activation of the alternative complement cascade, either through an autoantibody or through a genetic mutation. However, when you see pathology, often it's a reflection of what's happening in the body. And for instance, infections need complement in order to rid the body of infection. And there's really no way sometimes to distinguish the pathology report from C3G, which includes C3GN and dense deposit disease, and an infection-related glomerulonephritis. Now, there are some subtle clues that can help push you in the direction of C3G versus infection, but sometimes it can be a challenge and a diagnostic dilemma. And so, for instance, looking at the type of deposits can be helpful, whereas in infection-mediated glomerulonephritis or PIGN, you can have large subepithelial humps. However, there have been reports of that seen in C3G and dense deposit disease. Some of the things you need to look at is the context of how this is occurring. For instance, a patient's hospitalized for an infection. Well, that's likely not going to be C3G. Sometimes the age of the individual is helpful. When we talk a little bit later about the randomized controlled trials, you'll note that the average age is in their 20s and 30s. You could also have the same pattern with someone with a monoclonal gammopathy, and so that needs to be looked at very carefully. And so when we talk about the trials as well, we need to look at resolution of the disease. For instance, having persistent low C3 level after resolution of the disease should trigger in your mind that maybe this was an infection that just made their underlying complement disorder be seen to the world. And so maybe they have like a mutation that wasn't causing overt disease that no one knew about, but now they had an infection and sort of triggered it. And that's why this is a challenging diagnosis, because when we get the path report, we see C3G or C3 dominant staining. We get excited and want to use these new drugs, but these new drugs come with a lot of side effects, and we need to make sure that we're really giving these to the right patient. So that's why Dr. Varshney described, make sure they have no infection, make sure they have no occult infection that might not be apparent, and make sure they don't have a monoclonal gammopathy. That's very important.
So I guess let's get to the ordering of labs, right? Would you be satisfied, Aarushi, with just complement levels, or would you want to do some send-out tests?
Oftentimes, they would say, I think, in a peer trial where they had patients with low C3, but it's not always seen. We don't always have patients with low C3 or rarely even low C4. But I think that is an easy test, a test that is available at many centers that we can order. So we can start with that. Like Dr. Sparks said, if someone is admitted and we're thinking about infection, we should do a very thorough workup to rule out any underlying infectious disease. Again, it comes down to the age also. If there is a young adult and they have pretty significant proteinuria, so I would say an infection has been ruled out, then maybe we can take a next step and do more send-out tests, like looking at nephritic factors, looking at autoantibodies, looking at factors. Age are not available at many centers, so they are send-outs, and they do also have a cost burden with them. Also, if it's an elderly individual, we need to rule out monoclonal gammopathy, for which we can order SPEB and free light chain and go from there.
I actually think that we've now talked about diagnosis, but I will say practically in my experience, having seen some of these patients and having seen post-infectious GN a lot, it is really hard. And the reason it's really hard is because you can have same patient profile. You can have patients who present with an infection which triggered a post-infectious GN, but an infection also triggers C3G, right? And C3G is not like once it's active, it's always active. It can also flare and go into remission. So I think you really have to have that clinical acumen also to pick up these diseases, unless there's a genetic mutation. If there's not a genetic mutation and it's something to do with functional assays, once things are in remission, they might be okay on your panels. for C3G as well. So again, that becomes really hard when you see these patients not in a flare situation, but subsequently trying to figure out what to do. I want to actually talk about treatment. I'm really excited to talk about treatment. So, Matt, there are a couple of studies that have come out in C3G world. Do you want to just describe that for our listeners?
It's really unusual to see two drugs approved in the same year with high profile publications. So that really gives us great options for our patients. And the other thing that I really love about this is neither one of them requires them to go to an infusion center. So there are two drugs currently available, which the community already has a little bit of experience with or heard about: iptacopan, the factor B inhibitor, and the trial name is called APPEAR. And then Valiant is the other one. This is a drug with pegcetacoplan, which is a inhibitor of C3. Interestingly enough, these have been used for a long time with another complement disorder called paroxysmal nocturnal hemoglobinuria. And so an important thing is there's a lot of experience with these drugs. Now, iptacopan is oral. Pegcetacoplan is subcutaneous infusion twice a week. Now, as Aarushi alluded to early, these are ultra rare diseases, and many nephrologists might see this once every 5 to 10 years. And so it's really hard to have huge trials. So we're not going to see the numbers of the SGLT2 inhibitor trials. And so in the APPEAR trial, which is iptacopan, the number of patients was just 35 in each group, 38 and 36 for placebo. And pegcetacoplan was in the 60 range for both groups. They had a little bit of differences in who they enrolled. The iptacopan group enrolled individuals age 18 to 60. They basically enrolled those individuals that had a diagnosis of C3G, whereas the pegcetacoplan had those with C3G, but they also included those with primary immune complex MPGN. I think to cast a little bit wider net, because if you look at the sensitivity and specificity for looking at C3 staining alone, you're going to miss some patients because obviously it's ultra rare disease and these are not very specific tests. Also, pegcetacoplan included those individuals with kidney transplants. However, it was just a handful in each group, 5 or so. The primary outcome in both of these trials was proteinuria reduction, but they also have secondary endpoints, which included GFR, and also they looked at kidney biopsies in patients that were on therapy. We rarely get that in a lot of our trials. So both of these trials just really quite impressive. So we'll start with iptacopan first. And it had a reduction in proteinuria of about 30% at 6 months, which was sustained. And they had an open label extension period in which the patients that were on placebo got the iptacopan and it worked in them as well. Now, the pegcetacoplan was even more impressive and it resulted in almost a 70% reduction in proteinuria. If you look at the subgroup analysis, really, it didn't matter what your age was, what your C3 level was, or really anything. It seemed to work across the board, which I think this is just opening up a new avenue for our patients, because prior to this, we didn't have a single randomized controlled trial. Iptacopan also resulted in stabilization of eGFR. However, the pegcetacoplan even had a more impressive stabilization. And I think what really struck me is that the C3 staining almost disappeared in the patients that received biopsies during therapy in the pegcetacoplan group. Now, safety is another important consideration and actually appeared quite safe. I will say, though, this is not a long duration of therapy, and a patient with a genetic mutation or an autoantibody formation might need to be on this drug for the rest of their life. And so we need to know what the long-term implications of this is, the need for immunizations and occasionally prophylactic antibiotics. When you give these drugs, you basically make it to where the complement cascade is not going to work. And it's really important for taking care of, especially encapsulated bacteria. There was one death in the pegcetacoplan group versus the placebo group, but it looked like most of the other things were fairly well balanced. I think that patient ended up having COVID. There was a few other infections that we're seeing, but not a lot. So it seems like they're very well tolerated. And now this has led to both of these drugs receiving FDA approval just within the last 4 to 6 months or so. So really, we're in a whole new era now, and it's going to be great.
Can we pause here for just a second? Complement cascade can seem really overwhelming. So I'm going to give you a quick 2-minute overview of how I think about it. I think of it as there are three systems. There's the classical system, which depends on antigen antibody binding. But in reality, IgA is a little bit controversial there. It is really in more lectin and alternative pathway. Lectin pathway is something where triggering happens because these proteins bind to sugars on bacteria and viruses. And then you have a third alternative complement pathway, which sort of has a takeover system where all of us have a little bit of auto-activated C3. Now, all of these have different triggering mechanisms, but go through C3, C5, and then there's a terminal complex, which is the soluble MAC complex that is then created. So if you're now thinking about the C3G, what essentially happens is the C3 breaks down to C3A and C3B. C3B then binds to factor B and makes C3BB, which is called C3 convertase. And this is like a feedback loop system. It keeps breaking down C3 over and over again. And so C3B and BB are just bound together as a convertase. So if you take away factor B, or if you take away C3 or C3B with pegcetacoplan, then you're basically affecting one of these two components of C3 convertase. And then eventually through this amplification loop, you affect C5 convertase, which eventually leads to this terminal complex cascade. Now, I don't really have time to go through all the details, but just to understand, both of these drugs that we'll talk about today, iptacopan and pegcetacoplan, are affecting factor B for iptacopan and C3B and C3 for pegcetacoplan.
All right. I know some of us have used both the agents, and I personally have had much more luck with the PEG than iptacopan. What are your experiences?
Well, first off, we're not going to let you get away with not saying the whole word.
Oh, pegcetacoplan. I can't.
If you look at the clinical trial data, it mirrors that. My experience is that pegcetacoplan is a bit more of a larger hammer, if you will, and that it's right in the crux of all three pathways. And so you're likely going to affect more patients with the disease. And I think the one thing to recognize is that a patient can have a disorder affecting multiple different areas. The autoantibody to C3 nephritic factor, C4, C5 nephritic factor, mutations in many different genes that regulate this system. We don't yet know if we can profile a patient to say, you would be better for this drug, but it seems that the pegcetacoplan might be better for most patients, but also we have a backup to say, all right, well, maybe a patient can't tolerate the subcutaneous infusions, and maybe they have a reaction to the drug, or maybe they don't respond to pegcetacoplan. We have an alternative agent to try as well.
The device is actually pretty interesting. It's not like a straightforward, like a EpiPen or Ozempic. It's like a device you put on your body and then give it like an hour to infuse it. And it does look like a parasite, but the pills could be appealing to some patients too. So again, patient preference may play a role as well. Some patients like injections and less pills. Some like pills. You still get proteinuria reduction either way.
Maybe it's important to talk about the vaccines. Aarushi, do you want to talk about what to do in that situation?
Yeah, so before we start this drug, we definitely have to ensure the patients are vaccinated against Neisseria meningitis and then Streptococcus pneumonia. Oftentimes, it needs to be done within 2 weeks. If they're not, and this is something where we urgently do need to start on the medication, then we can start prophylaxis antibiotics. We have options. The antibiotics are penicillin, augmentin, and if they're allergic, then we can think about ciprofloxacin.
A lot of these drugs are used in many other settings, and often our pediatric colleagues like to vaccinate and use prophylactic antibiotics as well, because really these patients are at risk, need to be monitored very carefully and given antibiotics if they have signs or symptoms of infection. Given this is NephMadness, it's a tournament. We got to have a winner. And for anyone who's interested in participating, this is just a way to have a debate, a discussion about different topics that are emerging in nephrology. And so I'd love to hear from this esteemed panel which one of these teams is going to not only win the game against each other, but win the whole tournament. So we can start with Dr. Jhaveri.
Oh, you don't want to
The most
We'll go to
important
Koyal.
person.
Well, Dr. Jain is next. Don't worry. I want to start with,
Nope.
and if you use the drugs, you have to pronounce them both.
So I would say I would go with the iptacopan and pegcetacoplan. I think it's not just C3 where these drugs are going to take over. Even if the C3 is activated by an infection, a month later, I think we could probably end up giving these drugs. Even if you have MGUS triggering the complement cascade, you might still have to use these drugs. Down the road, I think these drugs might be very good for TMA and other complement disorders. So I think forget the diagnosis, drugs wins hands down. So it's not just C3. I think it's going to change the rest of nephrology.
Well, that's pretty passionate. Let's go on with Dr. Jain.
So I will say that this one, I actually genuinely feel it's the medications. I feel like with nephrology, we haven't had for so long innovation. And now the past few years, we've had so many new drugs and it's become so exciting. As a fellowship program director, there's nothing more exciting to tell other incoming fellows. Look at the world of nephrology. We're really changing and we're really at the forefront of all these changes in medications that are coming up. And I agree with Ken. We have another NephMadness episode on IgA, right? That our listeners will be listening to. And we talk about one of these medications again. And who's to say the other one won't be used there either in the future, right? So there's just a lot of overlap between all these diseases which have had no treatment for the longest time and now all these upcoming treatments. The one thing that we didn't really mention in the midst of our discussion is iptacopan and pegcetacoplan. Both of them allowed MMF to be used. We now have some data on MMF plus iptacopan and MMF plus pegcetacoplan. So if you're thinking about IgA and other diseases, but regardless, my preference is the medications for sure. Should we go with Dr. Varshney?
Yeah, I would say team management for sure. It's so much has happened. You both said it so beautifully. It's going to reshape the world of C3G and just glomerular diseases. And it has such positive findings that we have seen so far. Obviously, we need to see what it's going to be like in terms of adverse effects in the next couple of years, how patients are going to behave. And also we need to know the duration of the treatment. There's a lot of things that we still are learning about it, but definitely have seen a lot of promising findings with the treatment. So definitely team management.
I don't have a lot more to say. That I think this is going to be a front runner to win all of NephMadness. That's team treatment. So yeah, like it's looking back, like right now in time, you can draw a line in the sand and look at all the papers that were done on this disease prior. And then we're going to see everything in the future. You're not even going to see someone even get a transplant with this disease. And to me, that's just an amazing thought, because if you look back at the case series from Columbia that looked at this recurrence post-transplant prior to the initiation of these drugs, and it's very, very high, even in their 30s on their second transplant. And so this is going to revolutionize that. And to me, like the patients really have a shot now, and that is just amazing. So I'm 100% behind the therapeutics here.
For our listeners, they heard it first here. So
Yes.
if this wins,
Yes.
I have no
We are-
inside connection.
I
Barred
don't know.
me
Dr.
from
Sparks
any
is saying this is
knowledge.
winning. This is winning.
I have never won NephMadness, just to be clear. And so I'm
Because
not
you
the best
created it.
person to look at it.
He's never won it, but he's always been second. You know, well, with that, thank you so much, everybody, for listening to our NephMadness episode on C3G. We'll see you next time. This is Kenar and Koyal signing off. Thank you, Dr. Sparks and Dr. Varshney, for joining us.
Thank you.
This has been GN in 10 from the International Society of Glomerular Disease. You can listen and subscribe wherever podcasts are found and tweet at us at ISGD Tweets. Thank you for joining us.
Whoa, that was a handful.
I need a break now.
You need a break. You said that without a breath. And like you had all these tongue twisters, beep, beep, pack to beep. I was just, what the heck?